many models that are being experimented with by providers and by payers. You see payers getting into the business of providing healthcare by buying up doctors' groups, for example. You see hospitals becoming more interested in participating in ACOs, patient-centered medical homes. But Dr. Fisher, maybe we can begin with you. People have long known about the perverse incentives in healthcare, right? And people have been experimenting with new payment models for a long time. So is this just payment reform on a bigger scale, or is there real evidence to show what the promise of some of these new payment models might be?
Well, it's a very different moment than it was 20 years ago when managed care first surfaced on the horizon, or even back 40 years ago when HMO, the term was coined. There's now a much greater sense of urgency than there used to be. Both the recognition of the impact that you already mentioned of rising healthcare costs on federal budgets, on personal income, and on business competitiveness around the world. But equally importantly is our recognition of the magnitude of waste, which we really didn't have before. I mean, if the consensus is correct, and I think it probably is, that we're wasting about 30% of U.S. healthcare spending on services that are avoidable, unnecessary, and possibly harmful, that certainly makes spending a lot feel like a really stupid thing to do. It's one thing to spend a lot for getting great care and great value. It's another thing to spend a lot for low-value care. So the sense of urgency is very different. The transition that is underway, I think, is being driven not just by fee-for-service and its volume increasing attributes, but as you mentioned, it causes fragmentation. But even more important than what it does is it puts in place this notion of accountability at the individual provider level, that I as a doctor am only responsible for the patient directly in front of me, or I as a nursing home am only responsible until I get them out and send them home. And so those three underlying problems, fragmentation, volume-driven care, and lack of individual accountability without shared accountability, have really driven the recognition that we need to move to new payment models. So they're basically three flavors: the patient-centered medical home, which tries to create incentives for individual physicians, primary care physicians primarily, to be responsible for improving care for their patients, for the patients who are seen in their practices. It has some limitations. Interestingly, of course, it has no incentives for cardiologists, sorry, Ralph, or surgeons to contribute to improving performance. No incentives for hospitals to do so. So it's got some limitations. Very important initiative to strengthen primary care. Second model, episode-based payments, which is paying for a given period of time for a given admission and a nursing home stay, perhaps afterwards, or for a joint replacement. As a single bundled payment, that creates wonderful incentives for the docs and the hospitals and the nursing home to actually talk to each other, to be accountable for the whole period of time and start to think about what are the outcomes and how could they improve the quality of care and reduce the costs. Challenge is it doesn't touch the volume-driven incentives of the system. You're still incented to do more hip replacements. And so the third models that are emerging, harking back to managed care, are this notion of accountable care organizations. Early evidence is, from surveys that we've completed, is there are now about 400 of these organizations which are taking varying degrees of risk for the care of a defined population of patients, and all of their cost with incentives for improving quality as well. Where those systems have been at it for a while, there is starting to be evidence that they can have an impact. So the first evaluation of this program, the physician group practice demonstration, showed that overall savings were relatively modest. Maybe 1% of total cost, i.e. nothing, pathetic, I think would be the technical term. But all of the systems participating in that demonstration achieved remarkable savings for their sickest patients. For patients who are eligible for both Medicaid and Medicare, they were able to reduce the cost by a 5% average across all the systems. The most important thing systems under these new payment models do is identify sick patients and try to take good care of them. That's how you achieve savings, keeping sick people out of the hospital, out of Boston's hospitals, for example, as I'm sure Ralph will help us understand. So the early evidence is promising. Lots more work needs to be done. It's moving much more rapidly than I would have anticipated 3 years ago when the ideas really first emerged.
Thanks. So Dr. De La Torre, you've been moving forward quite aggressively with a different type of business model at Steward. Can you help just give an overview to start off of what you've been up to?
Sure. I mean, it's interesting because we came to exactly the same place from a business perspective as Elliott came to from a public policy perspective. When we created Steward just 3 years ago, and it's important to remember, we're a 3-year-old company, we decided that we needed to create value. That was the purpose, that every great company becomes great because it creates value. And for us, we decided to put our value creation along 4 major pillars. Access. And access wasn't just the need to be able to serve everybody regardless of their socioeconomic status. It also meant the ability to interface at various entry points. In other words, we needed to have home health, we needed to have the physicians, we needed to have the surgery centers, we needed to have the hospitals. So it couldn't just be one entry point, it needed to be multiple entry points across an entire geography. So cost. We needed to, and we realized in Massachusetts that as access had been expanded, that if you did not deal with the cost by dealing with the underlying structure of how you provide care, cost will grow. Now, whether that grows by being shifted to small businesses or grows by being shifted to Medicaid expenditures, it grows, the overall cost grows. Quality, we needed to provide a highest possible quality product. And sustainability, I think Elliott will agree that, right now if you came to me and said you need to cut 10% of your cost overnight, I could do it very easily by dismantling all my care management systems and referral management systems and prevention and wellness. But in 3 or 4 years, the system that we have would completely fall apart. So within that structure, we realized that we needed a vertical, a healthcare vertical, so we needed to have intertwined in the system doctors as well as hospitals as well as home care, et cetera. And that we also needed to have it far more integrated, and it needed to be far more primary care based. And on the heels of that, it also became obvious that the structure, and we have to be a little bit careful of this, the structure of being a at-risk or, whether you call it capitated or risk or bundle payments or global payments, is all on a spectrum. What we aim now is for the ultimate, which is we aim now for 100% upside and downside risk that's a % of premium. That's important to us because we want to know that if we cut our cost that we provide something at, that it's reflected by a premium cost because it allows us to compete on the cost of premium, not just, again, just simply lowering cost. If you are in a huge insurance program, it's like peeing in a wetsuit. It gives you a warm feeling, but no one really notices. So it's important that it translates to the consumer. So along those lines, right now where we sit is over 90%, almost 95% of our commercial products are almost 100% fully at risk. We strive to be 100%. If we're not 100%, it's simply because the insurer can't do it, not because we can't do it. And along those lines, a lot of the incentives are aligned throughout the system. We learned a lot of lessons from the HMO. You can't do, we put in a lot of checks and balances. Hospitals and doctors and post-acute providers all sit at the table together so that no one side skews utilization towards them or away from the other inappropriately. We put in a high degree of quality metrics at actuarially. If you don't meet the quality metrics, then it's almost impossible to overcome them purely by the risk savings. So it requires a little, futzing around the edges. But we have, when the Pioneer ACOs came out, it was very gratifying to see that for us. First of all, it was 2 or 3 years behind what we were doing already, and furthermore, we didn't have to change or put together an experiment or do anything different. It's simply plugged into our model just like any other commercial product would.
Is there a challenge with scalability as Steward continues to grow? How do you think about making sure that some of the practices you've implemented in your existing system are sustained as you get bigger and bigger?
So first, let me just be honest. America, and I think we need to realize this, America is a very diverse country. Okay, the Steward model works great in this area and will work great in other areas. Socioeconomically, demographically, and purely from a mindset, there are parts of the country where this will not be the predominant model. And to think that we're going to have one model that encompasses the entire United States is flawed. And I firmly believe that's not going to be the case. So we just need to realize that. And anybody who travels the U.S. just sees that the very different opinions that people have in different parts of the country towards government, towards healthcare, towards, well, it took me years. For a while I realized, having spent most of my adult life in Massachusetts, that they were just wrong and bad because, they thought differently. And that's not the case. They just fundamentally think differently. So one of the problems is that there is no one model. Our model has one key element that makes it very difficult, which is that if you think about it, hospitals, physicians, surgeon center companies, home health, insurance, because we do the insurance part of it too in many cases, in order for our model to work, everybody has to give up a little bit of control. And you're talking about industries that fundamentally hate giving up any control. So the burning platform needs to be created on an area by area basis that allows systems, allows groups to come together and give up and concede some of the individual power so that it ties it all together. So I think that's the hard part. I think that one of the things that I said is that I thought that the Affordable Care Act was phenomenal, but it was going to bring the country to the edge of bankruptcy. But I thought that was good because it was only then that we were actually going to confront our demons and do what's right.
That assumes having a functioning Congress. I'm not sure
that
are there.
That would have helped.
Yeah, I think they'll bring us to bankruptcy long before the Affordable Care Act does.
Yeah.
Dr. Fisher, what do you see? As you mentioned these three different models, do you see health systems struggling to adapt them to their own environment? How do you see the question of scalability and replicating these models playing out?
I would agree completely with Ralph that it is such a diverse country that we're seeing an incredible variety of models emerge in different markets depending upon the market context. So there are some systems that are essentially hospital-based. That's where most of the capital has been sitting. And it's where you're able to fund the integration and invest in the primary care practices. That will work in some communities. There are plenty of places around the country where small physician or even large physician groups or networks of physicians who are all primary care physicians are being pulled together to form an integrated delivery system. Optimus Healthcare in New Jersey, 550 primary care docs, with some selective contracts with hospitals, but they're not carrying the burden of cost structure that the hospitals have to bear, and they can easily afford to reduce hospitalization rates by 50%, and the only person who's hurt is the hospital. We see other systems emerging from the safety net, so federally qualified health centers in Minneapolis, pulling together a network of 10 of them, supported by a medical service organization, to try to coordinate and build an ACO out of the safety net. So I think the diversity of systems may be scalable to similar contexts. It may work again in an inner city where there are other safety net providers and you now have a model of how to put together community health centers to disrupt the US healthcare system, or you've got community hospitals that may be able to disrupt the academic medical centers, or you have groups of primary care physicians in New Jersey where twice as many physicians as you need on a per capita basis, probably the highest in the country, probably the highest in the world, maybe not Singapore, I'm not sure. But there, the primary care physicians may well disrupt the whole system. So I see incredible diversity out there and a challenging transition as they try to do all of the things they can, all of the payment models that are available to them from the payers to move into this new value-based payment model. So they say, let's do PCMH if our payers are willing to do a patient-centered medical home. We'll start to get an additional augmented payment for being in a medical home. Well, what about bundled payments? Medicare has some readmission, possibilities of doing bundles around readmissions. What if Cigna, which is quite active in this field, is willing to do an ACO-type contract? The places that appear to be most nimble in this are seeing the responsibility of those who are responsible for their contracts as helping them navigate this really difficult transition from fee-for-service-based payment. But how do we push as quickly as possible to where Ralph is, to really almost having everybody under global payment, which is the only place that's sustainable in the long run.
Yep.
And Elliott, get to your opinions. One of the concerns that I have is, at the end of it all, if it's not an integrated system that is the accountable care organization, and it's one component or the other that's the driver, let's say whether it's the payer or the hospital or the doctors, right? Because in different markets, some are completely physician-oriented, some are hospital-dominated, some are payer-dominated. Then as the first step is not going to be to create an ACO for the good of the entire system. There's no check and balance. The first step is going to be companies react as companies react, and hospital companies react as they do too, and so do the doctors. To maximize the system for the benefit of that one isolated component. And the other components are then get into trouble and get into a free fall. And at the end of the day, you need all the components in order to make it work. I'm afraid that an unbalanced system leads to destabilizing the healthcare reform in general. And in the long run, an unbalanced system leads to higher costs. The two highest cost providers in Massachusetts is a physician-run ACO followed by a hospital-run ACO. So the lack of integration, I worry about in the long run leads to problems. Now, what Elliott says is absolutely true. It gets it started, and then hopefully they act responsibly and recruit the other components.
Niels Bohr, I think, is famous for having said, prediction is really tough, especially about the future. And I've spent enough time looking at some of these models and then working with Clayton Christensen to try to understand how his theory of disruptive innovation applies to healthcare. And I look at these safety net providers and I look at the sort of facilitated networks, the insights that come from his more recent book and the folks in Sweden, Fjellstad, who talked about facilitated patient networks. And I don't know, whether a strong primary care-based system with a facilitated, engaged patients in a network supported by technology might not be able to, and home health care maybe, and maybe one hospital in some places that you refer, but not.
Well, but now you're not talking about a simple hospital system. You're throwing in components left and right.
I'm saying, how do you provide the best care possible at the lowest possible cost? And if I look at the Dartmouth Atlas, which I co-direct, our data would suggest that there are plenty of places in the country that are getting by with half as many hospital beds as Massachusetts. And so maybe 30 or 40 or 50% of the hospital beds in the United States could go away. Now,
so I agree with you there.
So then how do we develop an integrated model that has good hospital care and great primary care and keeps people out of the hospital?
What about the question of prices, though? So we've talked about sort of the incentives and how you align interests. There seems to be tension between a real sole focus on volume and this issue of prices and price transparency. How do you?
There is no focus. Well, volume is not an issue. If you do your incentives correctly, volume becomes a non-issue. Every component, everything in my system except for the covered life is a cost center, period. Everything's a cost center.
So volume is important.
Yeah. Well, volume of covered lives, not volume of individual procedures.
Is an important driver of costs. Right. So
there are many important drivers of cost, right? And so how do you think about this price problem?
I think it's a really important problem. Someone's got to cast a light. Oh, is there a company called Cast Light? Someone's got to cast a light on what's happening in the commercial market with potential consolidation and the potential impact on monopoly pricing. The argument, many people argue that prices are what's driving healthcare costs in the commercial market. Well, it's probably the majority. But that ignores the fact that there are plenty of communities where hospitals are able to keep prices down and control costs. So it's a choice on the part of hospital leadership. Do you want to rip off your community?
So what propels the change? What propels the choice to not rip off the community if that's the goal?
I hope transparency, and any board members on hospitals out here, I hope you guys start asking questions not just about revenue, but about how you're improving health and costs for your communities.
So, one on the other side, right? So in Massachusetts, all of our hospitals are added up roughly around the median, and we provide a lot more services because, remember, in total medical expense is included our entire care management costs, which most hospitals don't carry. We have care managements and claims, and we basically have a fully functional insurance company that's inside that cost structure, and we're still at the median. I agree with Elliott, except I think in Massachusetts that was 5 years ago. That time has passed. So escalating cost in Massachusetts, a unit cost basis, is not going to be the driver in the future. It is currently becoming a problem in the rest of the country. I don't view it necessarily. I think it's monopolistic practices are difficult to understand in healthcare because what constitutes a monopoly varies by geography and varies by payer. For example, if you have a hospital in a suburban area, right, the Medicare, Medicaid patients, Medicaid mostly, go to their local community hospital, period. So what constitutes a monopoly is literally the primary service area of a hospital. Commercial patients, and Medicare somewhere in the middle, will travel distances. So what constitutes a monopoly is a much wider and much larger geographic expanse. So you have to be careful that in an attempt to not create a monopoly at the commercial level, by not allowing geographic consolidation, you don't put small community providers out of business and endanger the Medicare, Medicaid populations. Yeah, because it's different. It's very complicated.
What about this issue of transparency? Because there is a distinction between consolidation and monopolies and the question
you know
of
what?
transparency.
I hate to tell you this. I mean, we fought this mess. People don't give a crap. The average patient pays a premium and has a copay. The average Medicare, I mean, we're 65% Medicare, Medicaid. They don't actually decide where they're going to go based on what the government theoretically pays a hospital. Now, if it impacts their pocketbook, then yes. But as far as the cost, no. And it comes back to what I said originally. You have to find a way where cost translates to premium. It can't go into an amalgam of insurance and then everybody gets the same price, because then it's not going to drive behavior.
Right. So I want to get your questions ready in the audience. I'll ask one more question for the panelists. As you pursue these models, a huge portion of any health system's costs are their labor costs. And how do you think about restructuring the labor force within the healthcare system, trying to get the most value out of doctors, physician assistants, nurses, and are regulatory changes required? How do you wring the most value out of labor and health?
There's a lot you can do without regulatory changes. I mean, it is amazing how much of a physician's time is spent doing stuff that's way below what they're trained for, whether it's paperwork or specialists spending a lot of time taking care of routine care. So there's all sorts of work that can be done, whether it's in primary care offices to restructure and use health coaches and nurse educators and data managers to prepare the patient for the visit, and do a lot of the care without even seeing the physician. Same is true in hospitals, same is true for specialist care, so there's a lot that could be done. There is an awful lot that could be done to loosen up regulations to make it smarter, nimbler, better. Why can't a Meals on Wheels person open somebody's pill bottle? Incredibly silly.
So I'll give you an example, a real-life example that illustrates the problem. As we incorporate all of our care management systems, we have markedly decreased utilization across our system, including Medicare readmissions, 50% decrease, which everyone would applaud. So 35% of our business is risk, 65% is government. Now the 35% that's risk, that's fine, because then we share in the upside enough to cover the lost volume per se. And then in Medicare, there is no risk. They get the benefit of the downside. Now you say, well, that's great. Here's the catch, right? You don't actually save money by just using hospitals less. The reality is you save money by decreasing hospital infrastructure or high price point infrastructure. You actually got to lay off people. You actually have to decrease, number of beds. It's a physical infrastructure. The problem is that current labor practices lead to laying off of the younger, usually higher degree, but younger staff that is much cheaper. The difference over a 10-year span of an incoming nurse assistant, but that level with the highest is 100%. It's double. So what you've done is when you do the math, you markedly increase your per discharge hospital cost. So for everything being the same, because labor is 60% of cost, you have dramatically increased the cost, but Medicare is not paying you at a higher rate, so you just shot yourself in the foot. And that's a very real problem, leading to literally $100+ million a year swing in us.
Very important.
Any questions from the audience for our two panelists? There'll be someone with a microphone coming around to you. Yes, just right here in the front.
Of course, we can only see the front. So.
Yeah.
If you say who you are and be sure to keep it to a question, please. Thanks.
I'm Deborah Prothro-Stith at Spencer Stewart, former health commissioner here in Massachusetts. Two questions. One about federally qualified health centers and neighborhood health centers generally. Is there an example, because many claim that they do what managed care and others have been trying to do for less cost. And I'm wondering if there's an example of their integration into ACOs or medical homes, and whether Steward is using any of the rich landscape we have here in Boston. So that's the first part, sort of federally qualified health centers. And then the second question is about pharmacy-based clinics, which with changes in the way providers are now able to do care, pharmacists providing care in some situations and other levels of providers. How do you see that becoming a part of an ACO, and do you ever see them being the lead organization in an ACO?
So we do both. I'll give you one example. We have several, but one example is Manit. It's a community health center out of the Quincy area that we have fully integrated into Steward. I think that the community health centers are great at not only controlling costs, but doing care management for a defined population. But again, it comes back to different flavors. I mean, I don't think that Manit would be very good dropped into Wellesley trying to manage that care. It's just a different socioeconomic expectation, and it's difficult to manage. So I think they are great, fully integrated. They do full risk for us. They use all of our they're fully part of Steward for all practical purposes. Now, I'm sorry, what was your second question? Oh, pharmacy. So we have a huge pharmacy component in our home health. Okay, we think, and we found that the largest reason Medicare patients get readmitted is they don't take their medicines appropriately on time, they don't fill their prescriptions, et cetera. So we've actually partnered with a company, Dovetail, that literally puts pharmacists in patients' homes as part of the home care experience. We also have some not only inpatient pharmacy, but outpatient pharmacies that are tied to select products in our network so that patients get cheaper drugs through mail order and other such things. We partner with CVS. It's a very difficult model because it doesn't lend itself to continuity of care, and much of care management is about the continuity of care. It's not just about the episode. But we do partner with CVS and their minute clinics, and have found that to be, urgent centers are the same way. We have a lot of urgent centers that we partner with also.
Dr. Fisher?
And Walgreens has launched 3 ACOs in the Medicare Shared Savings Program, where really a lot of the care management infrastructure is being built by Walgreens to support a partnership with primary care physicians around the pharmacy itself. So there are more disruptive models out there besides the partnership with Minute Clinic for urgent care. The other model that you should look at for community health centers is the Minneapolis Federally Qualified Urban Health Center Network, Urban Health Network. 10 FQHCs that have come together in partnership with Optum to develop an integrated model. And using data, they've discovered, which I'm sure was what Steward is able to do, is when you look at the data, you can find out who the patients are who need attention, and really track them and provide much better care. The capacity of the behavioral health folks and the others in the CA community health centers is often much greater than is in established health systems.
Right.
Any other questions from the audience? Yes, this table to the left. Yep, someone will come right to you with a microphone.
Tarek Abu Jabbar, I'm with the Harvard Pilgrim here in town. And I spent 7 years before I joined Harvard Pilgrim with Anthem nationally. And I'm really interested in, as we all are, in the growth of ACOs. And they're this vast, poorly defined thing. So you both spoke briefly about them. A particular question, there's lots of reasons we could all teach classes on it about why the HMO movement in the early 90s failed, and we don't need to go into that. But one of the things it had going for it, at least economically, not politically, was that people were engaged in a closed system. And of course, Harvard Pilgrim's own history as a staff model plan worked actually quite well. But we'll all remember, I think many people here are old enough to recall the tragedy of Hillary Care, and it was brought down largely on this issue of choice. We as Americans value this red herring we call choice, and imagine that if I wanted to run across the street and get an MRI, by gosh, that's my right. Okay, so now we have, 2013, we have ACOs, and they're largely built on a platform of PPO product. And I was with Anthem. We built some very, very large ACOs in Southern California, and there were these organizations had thousands of physicians, so it was very hard for patients to leave the system. Now, in a place like Massachusetts, we don't have that, or in New Hampshire in particular. And I'm wondering how the issue of this open network product, and I'm particularly focused on commercial product, is going to be able to survive in this full risk environment you talk about of an ACO.
I suspect it's an evolutionary process. So that most a lot of the discussion on the Hill and elsewhere around what could tweak the model more effectively is about how you can provide incentives to engage patients and encourage them to stay within the network. The importance of choice is it is American, but it's also a safety issue. It's also a perspective issue of the best way to protect an individual is to give them the sense that they're not being trapped in a rationed system with death panels. They've got some ways of getting around it. And the places that we see trying to do it really well are doing it through very active patient engagement. The strategy of the grass is always green, the grass will be greener here than anywhere else. Or in a Vermont or New Hampshire phrase, the best fence is a good pasture.
I'll take a little bit of a different approach with my optimism. I think
I'm optimistic too,
yeah,
promise.
well, so my biggest issue is that we have passed all this legislation, all of these guidelines for what amounts to 30% of healthcare, 35% of healthcare. And that 65%, which is Medicare, Medicaid, and the government, does not follow their own rules, which they're forcing commercial to follow. In Medicare, there is no requirement that you even have a primary care doctor. In our own Pioneer program, if you match every cohort across demographically and for comorbidities, the only outlier that falls out from cost is whether or not they have a primary care doctor. Medicare is not an entitlement, it's a health insurance. And until we start thinking of it as a health insurance and not an open entitlement, we're going to bankrupt this country. Because I'll tell you what, we're pretty good these days at keeping people healthy till they're 65, and we're going to get better in the future. And Medicare is going to end up going from 60 to 65% to 80% of the total healthcare expenditure because we're getting really good at keeping people alive and healthy till they're 65. And we got to start changing Medicare.
Okay, so on that politically divisive note, we'll end. Thank you so much for joining us. I hope that the conversation continues during the networking breaks, but please thank our two panelists.
Great. Thank you.
Thank you. Thanks so much.